For 100 years, medicine had a standard answer for emphysema. I'm sorry, the tissue is destroyed. It cannot regenerate. Learn to live with less. And for 100 years, that answer was correct. In 2024, something changed. I'm Dr. Becker, and what I'm about to share with you is not theory, not unfounded hope, and not the kind of promise you hear from clinics charging $50,000 for treatments with no evidence behind them. What I'm going to show you today is published in one of the most rigorous scientific journals in the world, and it fundamentally shifts what we believed about whether the human lung can or cannot repair itself. Let me start with a number. 15% of adults over 40 in the United States have some degree of obstructive lung limitation. Emphysema, which is a specific form of pulmonary tissue destruction, affects millions of people who right now are trying to climb a flight of stairs and have to stop halfway, who walk out to the garden and need to sit down before they reach the far end, who gave up things they loved because every activity became a negotiation with their own lungs. If any of that sounds familiar, this video is for you. What I'm walking you through today has 3 parts. First, the scientific discovery that shook what all of medicine assumed about destroyed lung tissue. Second, the biological mechanisms that explain why the emphysematic lung keeps deteriorating even after someone stops smoking, and why that matters for what you can do starting this week. Third, a practical, evidence-based protocol that any person with emphysema can begin implementing now, while the science of progenitor cells advances toward patients. If you're finding this kind of investigation valuable, subscribing to the channel helps me keep dedicating time to it. No pressure at all. I just mention it because it's what allows me to do videos like this one. Now let me tell you what happened in Shanghai. In September 2023, at the European Respiratory Society International Congress, one of the most important pulmonary medicine conferences in the world, a team of researchers from Tongji University in Shanghai presented something nobody expected to see. Dr. Wei Zuo and his team had followed 20 patients with moderate to severe chronic obstructive pulmonary disease for 24 weeks. All of them had received a transplant of their own lung progenitor cells, a specific type of cell the researchers call P63 positive cells. The finding that stopped the room was this. 2 of those patients, the ones with the mildest degree of emphysema, showed something on their 24-week follow-up CT scans that medicine had considered impossible. The emphysema lesions, the destroyed airspaces visible on imaging, were gone. Not reduced. Gone. That is the first time anything like that has been documented in human beings. But there's more. The full study, published in Science Translational Medicine in 2024, reported data across all patients that reveals the actual scale of what's happening. Diffusing capacity, which is the measure of how efficiently the lung transfers oxygen into the bloodstream, improved in the treated group by 18.2% from baseline, while in controls it fell by 17.4%. That's a difference of nearly 36 percentage points between groups. The distance patients could walk in 6 minutes, one of the most reliable indicators of real-world pulmonary functional capacity, increased by more than 30 meters on average. Quality of life scores improved by 7 points, which is above the threshold of clinical significance that researchers consider genuinely meaningful for the patient. And all of this occurred without a single serious adverse event. Now, I want to be completely honest about the limitations of this study, because honesty is exactly what you need to make informed decisions. This was a phase I trial, which means its primary objective was to demonstrate safety, not definitive efficacy. The sample size was 28 participants, with only 3 in the control group, which is small for drawing categorical conclusions. The study was open label, meaning there was no double blinding. Phase 2 and Phase 3 trials with larger samples are required to confirm these results at scale. What is clear, and this is the crucial point, is that we are looking at the first demonstration in humans that the lung's own resident progenitor cells can, under specific conditions, initiate a process that medicine considered biologically impossible. And that changes the questions we ask. The question is no longer whether the lung can regenerate. The question is when, in whom, and under what conditions. To understand why this discovery matters so much, and why the practical protocol I'll give you at the end of this video actually works, You need to understand what's really happening inside the emphysematous lung, not at the level of symptoms, at the cellular level. The healthy lung is a remarkable structure. It contains approximately 500 million alveoli, the small air sacs where gas exchange occurs. Every time you breathe, these alveoli expand to capture oxygen and release carbon dioxide. The walls of the alveoli are incredibly thin, just one cell thick, to allow gases to pass efficiently into the bloodstream. Think of those walls as the membrane of an extremely fine coffee filter. While the filter is intact, the process works. When the filter tears, everything degrades. In emphysema, those walls are destroyed, and the first mechanism you need to understand is why that destruction happens, because many people assume it only occurs while you're actively smoking. That's not entirely correct, and that misunderstanding leads many former smokers to abandon any active intervention under the assumption that they've already done what they could do. Here's what actually happens. Cigarette smoke, and also environmental pollutants, activates immune cells inside the lung called macrophages and neutrophils. These cells exist to protect you, but when chronically activated, they begin releasing enzymes called proteases, specifically MMP9, MMP12, and neutrophil elastase. These enzymes are literally molecular tools designed to destroy tissue. Under normal conditions, they're controlled by antiprotease proteins that inhibit them. But when inflammatory activation becomes chronic, the control system becomes unbalanced. The proteases win. They begin degrading the elastin and collagen of the alveolar walls. The alveoli collapse and merge into larger useless spaces. The problem is that once this activates the central inflammatory pathway called NF-κB, the master switch of inflammation, that switch can remain on in a self-perpetuating manner. Smoke starts the fire, but the fire learns to maintain itself. This explains something that confuses many patients and their families. Why does emphysema keep progressing years after someone stops smoking? The answer is that you stopped adding fuel, but the inflammatory cycle that the fuel set in motion can continue under its own momentum, especially if factors like diet, sedentary behavior, or continued pollutant exposure keep feeding that cycle. For people over 50, this mechanism has an additional dimension that almost nobody mentions. After that age, endogenous glutathione levels, which is your cell's primary antioxidant, naturally decline. Glutathione is what neutralizes the free radicals produced by chronic inflammation. When its levels fall, the lung's capacity to defend itself against the oxidative damage sustaining that inflammatory cycle decreases significantly. The same inflammatory mechanisms that in a 30-year-old would produce a certain amount of damage will, in a 60-year-old, produce considerably more, simply because the defense system is already weakened. That is the first mechanism, chronic self-perpetuating inflammation, and it is completely modifiable with the right interventions. The second mechanism explains why two people with exactly the same smoking history, exactly the same pulmonary function tests, can have completely different trajectories 10 years out. And it also explains what the patients in the Shanghai study who responded best had in common. Inside the bronchial epithelium, the inner lining of your airways, there exists a population of cells that for decades went unnoticed by researchers. They are called p63 positive basal cells, or the lung's resident progenitor cells. These cells are not stem cells brought in from somewhere else. They're cells that have lived in your own airways your entire life, waiting for a sufficiently strong repair signal to activate them. Under conditions of acute lung injury, these cells have the capacity to migrate from the bronchi toward damaged alveoli and begin differentiating into alveolar epithelial cells, the type of cell that forms the walls of the air sacs. In essence, they are the lung's internal construction crews. The problem in chronic emphysema is twofold. First, the number of these available cells is insufficient to compensate for the pace of destruction. Second, in aged and damaged lungs, their proliferative capacity is compromised. What Dr. Zhuo's team developed was not introducing foreign cells into the lung. What they did was extract via bronchoscopy the patient's own p63 positive cells, culture them in a laboratory for 3 to 5 weeks, to multiply them massively from hundreds of thousands to over a billion cells, and then reintroduce them via bronchoscopy directly into the affected airways. In other words, they took the lung's own repair workers, trained them, multiplied them, and sent them back in sufficient numbers to do the work they were individually too few to complete. The transcriptomic analysis of the study revealed something additional. The patients who responded best had higher expression of the p63 marker in the transplanted cells. The more robust the progenitor identity of the cells, the greater the benefit. This suggests that the quality of the cells matters as much as the quantity, and that intervening earlier, when those cells still have greater functional capacity, likely produces better results. That has direct implications. For someone with mild or moderate emphysema, the window of opportunity that this treatment could potentially leverage when it becomes clinically available is wider than for someone in a very advanced stage, which means the time to act is not when you're in stage 4. It's now. There's a third mechanism I need to explain, because it's the one that connects the p63 cell discovery to what you can do this week, and it involves something I call the air trap. When alveoli lose their walls, they also lose the structural support those walls gave to the small airways surrounding them. Small airways are normally surrounded by alveolar tissue that acts as a kind of elastic harness, keeping them open even during exhalation, when the pressure inside the lung tends to collapse those thin tubes. Without that harness, the airways collapse during exhalation before the air can fully exit. The result is that the lung progressively fills with stale air that cannot get out. The diaphragm, which normally has a dome shape when relaxed, begins to flatten because the lung underneath is permanently overinflated. When the diaphragm is flat, it loses the mechanical advantage that its dome shape provides. The accessory muscles of the neck and chest have to compensate, working with every breath at an effort that should be reserved for exercise. The patient feels they cannot breathe, even though paradoxically they have too much air in their lungs. What makes this mechanism clinically relevant is that it is partially reversible with specific breathing and muscle training techniques, even without any change in the anatomical structure of the lung. The respiratory muscles can be trained, the mechanics of breathing can be optimized, and studies demonstrate that those improvements translate into real, measurable reductions in dyspnea, greater walking distances, and better quality of life, regardless of what spirometry shows. This is something that's often not communicated well to patients. You don't have to wait for pulmonary function to improve in order to feel better. Pulmonary function and functional capacity are not the same thing. You can significantly improve one while the other remains stable. A meta-analysis published in 2025 in eClinical Medicine, part of the Lancet Group, analyzed 337 randomized controlled trials with 18,911 participants on pulmonary rehabilitation programs. The results are unambiguous. The combination of supervised aerobic training with inspiratory muscle training produces significant improvements in exercise capacity, quality of life, and dyspnea, even in patients with severe and very severe emphysema. That is moderate to high level of evidence according to the grade system, which is the most rigorous standard of evidence evaluation in medicine. And there is a fourth mechanism that few physicians explicitly connect to the lung, even though the evidence is solid and directly relevant to what your diet can do. The gut and the lung maintain constant communication through the immune system. This is not metaphor. This is documented biology. The bacteria in your intestine produce molecules called short-chain fatty acids, specifically butyrate, propionate, and acetate, when they ferment the fiber in your diet. These molecules enter the circulation and have direct anti-inflammatory effects. They activate receptors on immune cells that reduce the production of TNF-alpha and interleukin-6, which are exactly the pro-inflammatory cytokines that sustain the inflammatory cycle in the emphysematous lung. A study published in Scientific Reports in 2021 by Yang and colleagues demonstrated that high-fiber diets attenuate the development of emphysema lesions in animal models through this mechanism. The link between gut microbiome quality and COPD severity has been confirmed in multiple human studies. Gut dysbiosis, the microbiome imbalance that becomes more common after 50, is associated with greater systemic inflammation and greater severity of respiratory symptoms. What this means practically is that what you eat is actively modulating the inflammatory conversation inside your lung, not indirectly or weakly, in a documented and measurable way. Now you understand the mechanisms. The chronic self-perpetuating inflammation that depletes the aging lung's antioxidant reserves. The P63 progenitor cells, the lung's own internal repair crews, now demonstrated to be activatable or amplifiable. The air trap you can fight with training even when anatomy doesn't change. And the gut-lung axis that connects what you eat to what happens in your alveoli. With those mechanisms in mind, let me give you the protocol. The question I get most often when I explain this kind of evidence is, "Doctor, that's fascinating, but I live in this body right now. The P63 cell transplant isn't available yet. What do I do today?" The answer has 5 priorities, and I'm going to explain them in the order that makes the most sense to begin. The first and most important is also the one most underestimated because it sounds too obvious. Formal, supervised pulmonary rehabilitation, not general exercise, not walking in the park. Pulmonary rehabilitation specifically, with prior assessment of pulmonary capacity, a protocol designed for your level of function, and supervision from a trained professional. Why do I put it first? Because the American Thoracic Society classifies it with a strong recommendation for patients with stable COPD, and the meta-analysis I cited earlier, with nearly 19,000 participants, demonstrates it's the highest impact intervention documented for quality of life in this condition, more than any supplement, more than any individual dietary change. The program must include 3 components: progressive aerobic training, supervised walking or stationary cycling, beginning at 60 to 70% of your maximum tolerated capacity and gradually increasing, strength training for the extremities, which is essential to combat the muscle loss, affecting between 30 and 60% of patients with severe COPD, and inspiratory muscle training, using a specific resistance device, which asks you to inhale against an adjustable resistance. Studies from 2024, published in systematic review databases, show this last component increases maximal inspiratory pressure by an average of 14 centimeters of water, which translates directly into less perceived breathlessness. And there are 2 breathing techniques you should learn even if you do nothing else. The first is pursed lip breathing. Inhale slowly through the nose for 2 seconds, then exhale through pursed lips, as if blowing out a candle, for 4 seconds. This creates mild expiratory resistance that prevents the small airways from collapsing during exhalation. It is the mechanical solution to the air trap I described earlier. The second is diaphragmatic breathing, which trains the flattened diaphragm to reclaim its primary function, instead of relying on accessory muscles. What this does in practice: within 2 to 4 weeks, most patients report a subjective reduction in dyspnea during activities that previously exhausted them completely. By 4 to 8 weeks, the 6-minute walking distance improves by an average of 30 to 60 meters, which is clinically significant. By 8 to 12 weeks, quality of life scores show improvements exceeding the threshold that researchers consider genuinely meaningful for the patient. The second priority is anti-inflammatory nutritional intervention, and here the relevant mechanism is the gut-lung axis I described earlier. The nutritional goal has 2 parts: reduce the inflammatory load, and provide the substrates the lung needs to sustain the repair processes we can stimulate. The pattern with the best accumulated evidence for respiratory function is the Mediterranean diet, reviewed in an analysis of 26 studies with 1,111 patients published in Nutrients in 2023. In concrete terms, this means the following: include fatty fish 2 to 3 times per week, preferably salmon, sardines, or mackerel. A 150-gram serving of salmon provides approximately 2.5 grams of omega-3 fatty acids as EPA and DHA. Those fatty acids compete with omega-6 in the arachidonic acid cascade and reduce the production of the same pro-inflammatory cytokines that are destroying lung tissue. A study published in the American Journal of Respiratory and Critical Care Medicine in 2023 followed more than 15,000 people for 7 to 20 years. And found that higher DHA blood levels were associated with slower rates of pulmonary function decline, with a Mendelian randomization analysis across 500,000 participants from the UK Biobank, suggesting this relationship is likely causal, not merely associative. Legumes like lentils, chickpeas, and beans should appear on your plate 4 to 5 times per week, not primarily for protein, but for the fermentable fiber that feeds the intestinal bacteria producing butyrate. Extra virgin olive oil as your primary fat instead of refined vegetable oils like corn or soybean, which carry a pro-inflammatory omega-6 profile. Berries and citrus fruits for their flavonoid content with documented antioxidant effect in lung tissue. Dark leafy greens for magnesium and folate. What to minimize? Processed meats like deli products, sausages, and cured meats, which elevate systemic inflammatory markers. Ultra-processed foods with high refined sugar content, which feed the inflammatory cycle. And very large portions in a single sitting, because a full stomach pushes the diaphragm upward from below and worsens dyspnea, especially in patients with hyperinflation. The third priority is adequate protein, and I mention it separately from the Mediterranean diet because it addresses a specific and underestimated problem in emphysema. Sarcopenia, accelerated loss of muscle mass, affects between 30 and 60% of patients with severe COPD. It's not merely a cosmetic problem. The respiratory muscles, including the diaphragm and intercostals, are skeletal muscle. When you lose them, you breathe worse. The protein target for a person with emphysema should be 1.2 to 1.5 grams per kilogram of body weight per day, significantly above the 0.8 grams per kilogram recommended for the general population. That's difficult to achieve with 3 large meals, especially when eating a large quantity worsens dyspnea. The practical solution is 4 to 5 small meals distributed throughout the day, each with a complete protein source: egg, chicken, fish, Greek yogurt, legumes combined with grains. The important exception: if you have chronic kidney disease, that protein target must be adjusted with your physician because the damaged kidney cannot handle high protein loads. The fourth priority involves supplements with sufficient evidence to consider, and I'll be specific about which have real backing and which don't. The first is NAC, which stands for N-acetylcysteine. It is the precursor to glutathione, the primary antioxidant of lung cells. Remember, I mentioned that glutathione levels naturally decline after 50. Oral NAC is the most efficient way to replenish that precursor. A meta-analysis published in Archivos de Bronchopneumologia in 2024 by Papi and colleagues analyzed 20 studies and found that NAC reduced exacerbations versus placebo with an incidence rate ratio of 0.76, which is statistically significant. In patients with chronic bronchitis or pre-COPD, it increased the likelihood of symptom and quality of life improvement by 3.47 times versus placebo. I want to be honest about the controversy because it is real. A randomized controlled trial published in Nature Communications in 2024 by Joe and colleagues did not find significant reduction in exacerbations with high-dose NAC in mild to moderate COPD. The evidence has nuance. What most experts conclude is that NAC likely has greater benefit in more severe stages or in those with higher oxidative burden. The dose in studies with positive effect has been 600 milligrams daily for chronic bronchitis and 600 milligrams twice daily for established COPD. 2 important precautions. If you take warfarin, NAC can potentiate its anticoagulant effect, so monitoring your INR is essential. If you take nitroglycerin, NAC potentiates vasodilation and can produce significant hypotension. Do not combine them without medical supervision. The second supplement with real evidence is vitamin D. Between 60 and 80% of COPD patients have vitamin D deficiency. A 2024 Cochrane review finds suggestive evidence that correcting severe deficiency, defined as 25 hydroxyvitamin D levels below 10 nanograms per milliliter, reduces the frequency of exacerbations. The first step is not to supplement blindly, but to measure. If your level is below 20 nanograms per milliliter, supplementation of 2,000 to 4,000 international units daily under physician supervision is reasonable. If your levels are already normal, additional supplementation has no demonstrated benefit. The main precaution is in people taking thiazide diuretics, where the risk of hypercalcemia increases, and in people with Addison's disease or other calcium regulation conditions. The third is magnesium, specifically in glycinate or citrate form for better absorption. Magnesium has documented bronchodilatory effect, and intravenous magnesium is used in emergency settings for severe COPD exacerbations. The oral evidence is less robust, but the safety profile is excellent at 200 to 400 milligrams daily in people with normal kidney function. The critical exception is renal insufficiency, where magnesium can accumulate to toxic levels. And the fifth priority is something that is neither a supplement nor an exercise, but an evaluation that many emphysema patients never receive: a sleep study. Between 20 and 30% of COPD patients also have sleep apnea, which is called overlap syndrome. When the two coexist, the prognosis worsens significantly. Nocturnal hypoxemia accelerates cardiovascular damage, and sleep quality deteriorates in a way that amplifies daytime fatigue and reduces exercise tolerance. If you have snoring, excessive daytime sleepiness, or frequent morning headaches, ask your physician to evaluate for sleep apnea. A correctly calibrated CPAP in that context can make a difference that no supplement matches. Now, I need to talk to you about what this video is not, and I say this clearly because your safety and your money deserve that clarity. The p63 positive progenitor cell transplant I described at the beginning of this video is not available at any clinic in the United States, Europe, or elsewhere with backing from the FDA or equivalent regulatory bodies. The only legitimate access at this point is through certified clinical trials. If you are interested in exploring whether any trial exists for which you might qualify, the clinicaltrials.gov, http://clinicaltrials.gov, registry is the correct place to search using the terms P63 and COPD or emphysema. What does exist, and what charges anything between $15,000 and $50,000 for stem cell therapy for COPD in commercial clinics is largely a minefield. Conventional mesenchymal stem cell therapies, the MSCs derived from bone marrow or adipose tissue, have been evaluated in multiple phase 2 clinical trials for COPD, and the results have been consistently disappointing. There is no demonstrated efficacy. Clinics selling these therapies are selling hope without evidence, and in some cases are generating real risks, including adverse reactions, infections, and the more subtle but equally real risk that the patient abandons interventions that do work because they invested their entire financial and emotional capital in something that has no foundation. The difference between conventional MSCs and p63 cells is fundamental. MSCs are cells from a completely different tissue, mesenchymal tissue, introduced into the lung with the hope they would adapt and repair. They are not lung cells. p63 cells are the lung's own resident progenitor cells, the cells that evolved specifically to repair that tissue. That biological difference probably explains why the Shanghai team's approach worked when previous attempts failed. I want to give you a realistic timeline. The research team behind the study, published in Science Translational Medicine, affiliated with Regen Therapeutics in China, has approval to proceed with phase 2 trials. Regulatory processes vary across different geographies, but a horizon of 3 to 5 years for clinical availability in China, with broader Western access likely requiring additional time, is a reasonable estimate. This is not tomorrow. It is not never. It is in the pipeline. What you can do with that information is make the right decisions now. If you have mild or moderate emphysema, the period between today and when that treatment becomes available may be the period in which you preserve enough pulmonary function to respond well when it arrives. The study evidence shows that patients with milder emphysema had the most striking results, including those 2 cases of imaging resolution. Acting now is not waiting, it is preparing the ground. Let me give you the timeline of what to expect with the protocol I described. During the first 2 weeks, if you begin pulmonary rehabilitation and the breathing techniques, you will likely not see changes in pulmonary function tests because those are not the first things to improve. What you may notice is a slight reduction in the sensation of breathlessness during activities that previously exhausted you completely. That occurs because respiratory muscle training and the optimization of ventilatory mechanics have effect even before the muscles have gained significant strength. By month 1, if you have also implemented the dietary changes, systemic inflammatory markers like C-reactive protein begin moving in the right direction. Most people report improvement in sleep quality, partly because optimized posture and the anti-inflammatory diet reduce upper airway inflammation that contributes to nighttime congestion. By months 2 to 3, the changes become objectively measurable. 6-minute walking distance improves. Quality of life scores improve above the clinically relevant threshold. Patients appropriately taking NAC may experience a reduction in exacerbation frequency. By months 4 to 6, the complete protocol, sustained pulmonary rehabilitation, Mediterranean diet, correction of vitamin D deficiency, NAC where indicated, and sleep management if apnea was present, produces improvements that in some cases exceed what family members and the patient themselves expected. Not because the destroyed tissue has regenerated, but because the tissue that remains is functioning with greater efficiency. The inflammation that was continuing to damage it is more controlled, and functional capacity has improved, independent of what spirometry measures. There is something I want you to understand about the situation you're in, if you have emphysema, or if someone you love does. For a long time, the message patients received was nihilistic, irreversible damage, no options, learn to live with less. That message was medically honest, given the evidence available at the time. And it had a real cost, not just the emotional cost of resignation, but the practical cost of people who stopped looking for interventions, stopped moving, stopped eating well, stopped actively engaging with their health because they'd been told it didn't change anything. The 2024 discovery doesn't resolve everything, but it does change something fundamental, the conceptual framework. We are no longer debating whether the human lung is capable of some form of regeneration. That is demonstrated. We are debating how much, under what conditions, and over what time period. That is an entirely different conversation. And the practical protocol I described is not a bridge to an uncertain future. It is solid, peer-reviewed evidence applicable today. Pulmonary rehabilitation, Mediterranean diet, correction of nutritional deficiencies, sleep management, all of that carries moderate to high level of evidence by the most rigorous standards in medicine. It's not the promise of a 2024 discovery. It's the consolidation of decades of research that too many patients never receive because the healthcare system doesn't have time to sit down and explain it in detail. The fact that you're here, seeking to understand more deeply, already puts you ahead of most people with the same diagnosis, not because you have access to secret information, but because information is the first step of any effective action. You have more capacity to influence the trajectory of emphysema than you've probably been told. Everything I shared in this video is backed by research published in peer-reviewed journals. The numbers I cited are real. The limitations I noted are also real. The honesty about what the P63 cell treatment can and cannot yet be is also real, because my job is not to tell you what you want to hear. It's to give you the most accurate information possible so you can make the best decisions for your health. If you have specific questions about your situation, a family member's diagnosis, or any of the studies I mentioned, write it in the comments below. I read all of them, and the topics that generate the most questions guide what I investigate next. Keep researching, and I'll see you in the next one. Dr. Becker.